Well, good morning, everybody. Thank you for the opportunity to present today. I'm going to discuss some research that we published, as well as a couple of other publications that are forthcoming, looking at using county-level data to assess differential impacts of COVID-19 in communities of color. Now, this is a large study team that's been involved in this work. It's been my colleagues at AmFAR, colleagues at Rollins School of Public Health at Emory University, Johns Hopkins University, PATH, University of Mississippi, as well as Georgetown University. And for the first study that we published, it was a study trying to take a look at what's taking place in the Black community in terms of COVID-19 risk. We know that Black Americans are at elevated risk for COVID-19. There have been discrete data that were published throughout the country showing that African American communities were at higher risk for COVID-19 cases as well as deaths. But as of April 15th, there was 78% of current diagnoses for COVID-19 was missing at the national level. So what we thought would be helpful would be to devise an alternative method to estimate the impact of COVID-19 in Black communities. And the data that we're presenting are data that were published in the Annals of Epidemiology, and also available online on a dashboard that we have that follows COVID-19 by race and ethnicity. You can see the hyperlink there. So what were some of the research questions that we had for this paper? The first was, are COVID-19 diagnoses and deaths higher in counties with higher proportions of Black Americans? The second is, are associations between COVID-19 diagnoses and deaths independent of other confounders? And then the last research question that we had is, what modifiable social or environmental conditions can increase or decrease COVID-19 cases in communities with greater Black residents? In terms of methods, we use data that were all publicly available sources, the COVID-19 data that Hopkins and others are using from USA Facts, data from the census in terms of US counties and demographics of US counties, such as age, unemployment, insurance, number of occupants per room in households. Also data from CDC and their various atlases to take a look at comorbidities by race per 100,000 for heart disease, diabetes, cardiovascular disease, hypertension, as well as HIV, as well as data looking at social and environmental factors, such as social distancing. There's a new scoring system that was available from Unicast that actually grades counties across the US in terms of how they're doing in terms of social distancing, air pollution, urbanicity, as well as time since first case or death was detected. The data were as of April 13th, 2020, and we divided the counties by proportion of Black residents according to national data. So we compared counties with above average national data for African Americans, so greater than 13%, versus all other counties. And we went ahead and moved forward with unadjusted analyses and some regression analyses, a Bayesian hierarchical model, as well as looked at population attributable fraction calculations. So this here is a map of COVID-19 diagnoses per April 13th data in the United States. And the blue represents what's taking place in all other counties of the US. The orange is taking place in disproportionately Black counties in the US. This represents about 677 counties in the US that are disproportionately Black. And as you can see, 91% of them were concentrated in the southern United States. And this is COVID-19 deaths. Again, the same pattern with the disproportionately Black counties in the southern United States. And you can also see per 100,000 what's taking place in terms of where the deaths are concentrated as well for African American communities. In unadjusted analyses, we were curious to see if there are any difference in terms of demographics, chronic disease, social environmental factors, and COVID-19 diagnoses and deaths by proportion of Black residents. And as you can see here highlighted in the red, for those counties that had a greater proportion of Black Americans, we did see some differences. So we saw some differences in underlying infections and diseases such as diabetes, cardiovascular disease, greater rates of HIV infection, and also some of the social environmental factors, high rates of individuals who are uninsured in disproportionately Black counties, unemployed, greater occupancy per room in household. We also saw in the urbanicity score, urbanicity was graded as 1 being most urban, 5 being least urban. So Black counties were more urban than other counties. We saw greater air pollution in Black counties. And we also saw that in terms of mean social distancing, that Black counties were less likely to social distance compared to other counties. And we also saw higher rates of COVID diagnoses in Black counties, as well as higher rates of COVID deaths. We then decided to put this data into a scatter plot where we took a look at all counties in the United States. And you could see on the x-axis, we were looking at proportion of African Americans. And then on the y-axis were the cases per 100,000 per day of detection, standardized by day of detection. And as you can see, as the counties have a greater proportion of African Americans, when you go from left to right, you see this increase in terms of the scatter plot across counties for cases of COVID-19. And one of the plot lines that we have here that I highlighted is from Dougherty County, Georgia. You might remember that there was an outbreak that took place there from 2 funerals, rural county in Georgia, primarily African American. About 40 people were diagnosed with COVID-19 and about 10 people had passed away. So this is an interactive map that people can use and take a look at. It's a scatter plot that's available on our website. We were also curious to see whether or not there are going to be differences in diagnoses and deaths in disproportionately Black counties in terms of urbanicity. As you might remember, early in the epidemic, it was primarily an epidemic that was concentrated in the Northeast, and we weren't sure if this pattern was only something that we'd seen in the Northeast. So these are forest plots that are taking a look at those data, and it's comparing disproportionately Black counties compared to all other counties. And you could see for cases, it doesn't matter if it's a large central metropolitan area or if it's a rural area, that you see a greater proportion of COVID-19 cases taking place in disproportionately Black counties. For deaths, the pattern is somewhat different. For deaths, we see that deaths are greater for disproportionately Black counties in small metro areas as well as in rural counties. So it's interesting to see that this pattern of greater risk was taking place for disproportionately Black counties, irrespective of where they were. And in multivariable analyses, I mean, this is the thing that we were really most interested in, is when we put in all of the covariates into a model, we found that being Black or a greater number of Black residents was associated with COVID-19 cases, as you can see here, as well as COVID-19 deaths. So we knew that there was something that's clearly taking place here, even when you adjust for other covariates in the model. And then when you do adjust for other covariates in the model, there are some other things that popped out that we also thought that was interesting. For COVID-19 cases, you could see that percent uninsured predicted COVID-19 cases or was associated with COVID-19 cases. We also saw that household occupancy. So if you had a denser household, that was associated with COVID-19 cases. And we also saw that social distancing, so less social distancing, was associated with higher COVID-19 cases. Last, we also saw that unemployment, so people who were unemployed were less likely to have COVID-19, and that certainly makes sense because if we find that African Americans are more likely to be employed as essential workers, which places them at greater contact with COVID-19. So if you're unemployed, you're less likely to have COVID-19. In terms of deaths, there were far fewer of the covariates that were statistically significant. One of them was percent on the counties that are over 65 years old, which makes sense. And then there was a few others that were statistically significant. Social distancing was one and some others. Then we're interested in taking a look at the population attributable fraction. We wanted to see what modifiable factors can increase or decrease COVID-19 cases in Black residents, with the proportion of Black residents. So we're looking at things such as insurance, population density, et cetera. And what we found is that being uninsured and living in crowded households increases risk for acquiring COVID-19 in disproportionately Black counties, and that unemployment was greater in disproportionately Black counties, and that this contributed to these counties having fewer cases. So in summary, for this first analysis, we found that using county level data are a valid proxy for estimating COVID-19 impact in Black communities, and that county level data can help identify emerging hotspots for COVID-19 COVID-19 within these communities. COVID-19 cases and deaths increase as a proportion of African Americans increase in counties, and being uninsured and crowded living conditions are associated with increases in COVID-19 diagnoses among Black Americans. Unemployment is associated with fewer COVID-19 cases because African Americans are more likely to work in jobs that increase exposure. Now, one of the things that we're interested in is this a pattern that is only relevant to the data that we collected it from, so from April 13th. And we found that when we reran the analysis a month later, that we found exactly the same association, that African Americans who were, a greater proportion of African Americans in counties was associated with both COVID-19 cases as well as deaths. So this is something that's durable. It's an association that's durable. One of the things that once we published these data, it made it all the way through the national media. There were quite a few media headlines that we had of this. One of this was that disproportionately Black counties account for over half of coronavirus cases in the US and nearly 60% of deaths. And that's certainly true. But we're also curious to see how durable that association was as well over time. So we created this GIF to take a look at disproportionately Black counties versus all other counties in the US. And you could see as the time is increasing, you're seeing a disproportionate increase as well for COVID-19 cases as well as deaths in Black counties. And this is something that we have on our website, along with other data looking at disproportionate impact of COVID-19 in communities of color, where we have a daily tally of what's taking place in each of these counties that are disproportionately minority. And near the end of this visualization, it gives you a summary of where we are in terms of those counties and the proportion of cases and deaths that they represent in the US. And here's a summary coming up. As of June 28th, 46% of cases and 53% of deaths are in the 22% of counties that are disproportionately African American. So this is when I created the presentation. This is actually something that is definitely up to date on the website and available for July 1st as well. Now, one of the things that keeps coming up over and over again in the media narrative about disproportionate impact among African Americans is a greater proportion of underlying health conditions. And we know that that's certainly true. We've seen it in our data as well, that you see greater rates of heart disease, diabetes, cardiovascular disease among African Americans. And you certainly see it here as well when you take a look at those counties that are disproportionately African American. But I think the main thing that we've learned from our study, and we're seeing in other studies as well, is that it's the social determinants of health that are really driving these higher rates of COVID-19 in disproportionately Black communities. Is you could also see here higher rates of poverty, unemployment, uninsurance. And as I showed you beforehand in our multivariable analyses, underlying health conditions were actually non-significant. What was significant were the social determinants of health in predicting cases as well as deaths in disproportionately Black counties. Now, we're also interested in taking a look at Latinx communities, and we know that they're also at elevated risk for COVID-19. There's a paper that we have in press right now that Carlos Rodriguez Diaz is the lead author on, and I'm just going to show just one slide, one data point from it. These are forest plots, again, looking at urbanicity, and this time for Latinx populations. And when you're taking a look at COVID-19 cases, you could see that for those counties that are disproportionately Latinx, we see that these cases are elevated in medium metro counties all the way down to rural counties. And when you take a look at COVID-19 deaths, you see that they're primarily confined to medium metro counties, where we see a disproportionate number of deaths in those counties that are disproportionately Latinx. Another thing that we're interested in is looking at COVID-19 risk and what's taking place demographically since the economy has begun to reopen over the last few weeks. There have certainly been quite a few news stories just in the last week about surges in COVID-19 cases in Texas, California, Arizona, and Florida. And the New York Times actually scooped us, because we were working on a paper looking at this, showed that many Latinos are at risk in many of these areas. And certainly that's something that each one of these states share, is a disproportionate number of Latinos. we took a look at those data, and we have that available as well on our website. And so for each of these cases, we compared Latinx counties versus other counties, and we looked at what has been taking place since May 15th, when many of the states have begun to reopen. And these are data from Florida. And you could see from nearly the beginning that Latinx counties, in terms of the 7-day moving average, has had the lion's share of cases compared to all other counties in the US. But now as the economy is starting to reopen, you can see that that sharp increase, the slope is much steeper in Latinx counties compared to all other counties in the US. The same exact thing is happening in California. Again, another one of the states where we're seeing this surge, where Latinx counties, as soon as we have begun to reopen our economy, the slope of that increase in terms of COVID-19 cases is much higher than in other counties in California. And then we're also seeing the same thing in Texas, where for Latinx counties, as soon as the country reopened, that we're seeing this, rapid increase in COVID-19 cases in those counties, and paradoxically, a decrease in some of the other counties. And some of this can be explained, and some of this is actually really not showing the extent to all of this is happening. We know that both Blacks and Latinos are more likely to test positive for COVID-19, but are less likely to get tested for COVID-19. So all the data that I'm sharing with you are likely underestimates of what's really taking place. So for instance, NPR ran a story a couple of weeks ago where they were looking at COVID-19 testing location in big cities in Texas. And they found that for Houston, Fort Worth, and in Austin, that COVID-19 testing was located in disproportionately white neighborhoods. And that's the hot pink that you could see here, the percentage white, which is higher, as compared to those places where in the orange places where you could see that are more minority. And they saw that for Houston, for Fort Worth, as well as for Austin. This is something that's not just taking place in Texas. We've seen other analyses showing exactly the same thing for Philadelphia, for New York City, for Nashville, for many other places where when testing was first started, that it was being placed in communities that are less likely to be diagnosed with COVID-19. And thankfully, some of that is beginning to change. One of the big takeaways that we do see, though, is that non-white communities are at highest risk for COVID-19. And again, this is from the analysis that we reran a month later. And one thing that's fairly clear here is that when you take a look at those counties that are disproportionately white, you see that both for COVID-19 cases as well as for COVID-19 deaths, that those counties that are disproportionately white are far less likely to have COVID-19 cases or deaths as compared to disproportionately Black counties. And then when you take a look at white counties in the US, these are counties that are at least 67% white in the US versus all other counties, which are presumably counties that are non-white or have a higher proportion of non-whites. You can see that from the very beginning of the COVID-19 pandemic here in the United States, that disproportionately white counties have had fewer cumulative cases for COVID-19. And you see exactly the same pattern as well when you take a look at disproportionately white counties for COVID-19 deaths, is that they are far less likely to have COVID-19 deaths as well compared to non-white counties. So this is decidedly a racialized disease that's predicated upon the social determinants of health that are putting communities of color at highest risk. And if past, really serves as prologue, we knew that this was going to happen. A decade ago, we had swine flu. These were data that were reported from CDC. I'm a former CDC scientist. I was at CDC a decade ago during the swine flu H1N1 outbreak here in the United States. And these were the data that we were reporting at the time, is that African Americans, Latinx populations, as well as American Indian and Alaska Natives populations were more likely to be hospitalized with swine flu as compared to white populations. So we knew that this was something that was going to happen, another respiratory illness. And at the beginning of COVID-19, there were papers being written in Annals of Internal Medicine saying that we hope that this time would be different in addressing some of these racial and ethnic disparities with the pandemic, given what we had already seen with H1N1. But with the data that I just showed to you, unfortunately, we haven't. And communities of color are really bearing the brunt of COVID-19 in the US. And with that, thank you again for the invitation to speak, and look forward to hearing any questions that you might have about some of these data. Thank you.
Well, thank you, Greg, and for being a little bit ahead of time. We have plenty of time for questions. I'd like to ask one. What you're describing is a very profound infrastructure problems that probably can't be quickly overcome. But I wondered about the concept of providing high quality, effective PPE in a very concentrated way in the communities that are of higher risk. And have you looked at that in your analysis, or is that something that could be assessed, whether that can make a difference immediately?
It would be great to see if we could assess that. So there's no publicly available data, either at the state or the county level, of proportion of PPE that's being worn. So it's even mask wearing. We don't have those data yet. There are data, as I mentioned before, in terms of physical distancing by state, and that's really easy to look at because those data are predicated upon cell phone data.
Right.
We haven't seen data yet for mask wearing. We certainly know, though, that there's the politicization of this has been associated with less mask wearing in those states that are red states as compared to blue states, and less physical distancing as well in red states and blue states. But we haven't been able to see any data down to the county level for any of that PPE and mask wearing. And we're just not able to evaluate any of that yet. In terms of whether or not it would work, it would absolutely work. I mean, I think all of us have seen the data from the Lancet that was published a couple of weeks ago on consistent wearing of masks and the degree to which that's protective against COVID-19 compared to not wearing a mask at all. So that would certainly be something that would work. But unfortunately, we're still seeing this haphazard approach to COVID-19 prevention in the US, where essentially every state has a different plan, and different governors are either issuing mandatory mask wearing or they're not. And I think that unfortunately is going to be a detriment to some of the communities that I described in this presentation.
And then a follow-on question, which is related, looking to see whether there's a correlation between public announcements and education from, say, the Black community, with people who, could be relatable, not Mitch McConnell, for example, and whether that would correlate with reduced incidence and death rates.
That's a great question, and certainly something that's an incredibly astute observation. From the very beginning of this pandemic, there was, on social media at least, some descriptions from various African Americans that COVID-19 is something that is only affecting white communities. It's not affecting Black communities. The messaging wasn't necessarily there for Black communities. It's exactly what we saw at the beginning of the HIV epidemic, to tell you the truth as well, where many African Americans didn't think that they were at risk for HIV, that this was something that was primarily taking place in white communities. And lo and behold, you find that actually we are at greater risk for both HIV as well as COVID-19. That type of messaging, I think, would be extremely effective. Some of it is starting to take place. Oprah, a couple of weeks ago, had a large event around this, where she brought in various Black celebrities to talk about mask wearing and the fact that we're at higher risk. And all of that is helpful. But I think one of the big underlying issues that we still need to grapple with as scientists is the fact that there's still a high level of mistrust within the African American community, as well as the Latinx community, towards medical officials and to scientists in particular. We've seen, at least with HIV, that there's a lot of distrust and mistrust, that people believe that the government actually has a cure for HIV. And people don't necessarily believe in some of the messages that are being produced. We're seeing actually the same thing right now for COVID-19. If we have a vaccine tomorrow, there's a Pew poll that showed that African Americans and Latinos were less likely to trust taking a vaccine. So it's a lot of these same issues that we keep bumping up against that we still need to address.
Margaret, if you unmute yourself, you can ask a
Yes,
question.
yes, I have. Good morning. Thank you so much for just a really vitally important talk. And I couldn't agree more that the you know, of course. But I have two things that I want to ask you about. The first is about Alabama and Mississippi, because I noticed on your map there are clusters in Georgia, but it sort of skips over then it sort of lightens up a bit and then goes over to Louisiana. I was wondering what kind of data you're getting out of Alabama and Mississippi. The reason I asked that is because of the Black Belt counties, where at least from what I'm sitting, it seems like those numbers are really starting to balloon off the chain. But I'm also a little concerned about how the data might be getting reported, and be curious to see what you have to say about that. The other aspect of this then is a sort of policy aspect. I have been concerned because now there is a sort of ratcheting up of calls for isolating communities, contact tracing, quarantining communities. And these terms are, you know, in terms of community as opposed to individuals, and all this, of course, in the name of health security. This has been articulated, you know, by a number of people at the top, I would say. And I'm concerned about this because it seems to me that this is, given the data and given the concentration, that this becomes policing on a mass scale of these communities that, since they are disproportionately hit by COVID-19, will be disproportionately hit by all of these sort of policing measures.
I appreciate both of those questions, and you're certainly right that we do see a concentration in a black belt. So one of the things, if you go to this website here, the URL here, this is an interactive chart. So I was just showing, you know, one point here in Dougherty, but actually when you get out closer to here, where we're getting to, you know, greater than 70% of the counties being African American, most of those counties are actually located in the black belt, and quite a few of them in Mississippi. And then when you take a look as well at this, this is also located on our website, but this running tally, this GIF that we have, that shows where these cases are taking place and where these counties are, you see as well that, you know, the cases as well as deaths are really beginning to cluster around the black belt as well.
Yes, yes.
So that's definitely something that we're seeing. And then the last thing, and I completely, you know, agree in terms of, you know, the fear that we have and what we really need to guard against in terms of the policing that might take place. And we are, especially in the context of the fact that we already have such high mistrust within many of these communities. We haven't been seeing that yet. But, you know, I think some of that is the fact that the genie just might be out of the bottle when it comes to this COVID-19 pandemic. We saw that with Dr. Fauci talking about that, testifying yesterday, is that the numbers right now are escalating at such a point that we can't even do traditional effective contact tracing. It's just not going to be possible. So I'm not sure how people are going to be able to implement these programs. If they are, I do think that there's a role specifically for HIV community-based organizations. One thing that we've known in our HIV response, it's not just the scientists who've been able to really address HIV effectively in this country. It's us working in concert with community-based organizations who have the trust of the community. They know how to deal with stigma, and, you know, COVID-19 is stigmatized. They know how to reach populations that many people consider hard to reach, and they know how to get people into testing. And I think that there's more that we need to be doing, working with these community-based organizations that are trusted by communities to do this type of work, rather than the type of policing that I think both you and I would disagree with.
So
Thank you so much.
We have several more questions. If we could keep the questions brief and give everybody a chance to ask their questions. Jason, if you unmute yourself. Yeah.
Yes, hello, thank you. Did you get to see much data or research on specifically the effect of language? So, especially up here in Upper Manhattan, in the Bronx area, there's an intersection between the Black and Latinx community. So many people identify as both. And I saw myself like some of the linguistic disparities. So is there much data on the language barriers and how that affected outcomes?
Yeah, I appreciate that question. My family, I'm from New York City, from Brooklyn, and my family is Cuban and Panamanian, and I identify as both myself. And it is one of the things that we looked at, not specifically for this paper. I was more interested looking at it in our Latinx paper for the linguistic differences. And one of the things that we did find in that paper that's going to be coming out soon, and it's no surprise because we've seen it reported in the media, is that people who are monolingual Spanish speakers were at elevated risk for COVID-19. So that is not a surprise. We've seen that in data coming from some of the meat packing plants in South Dakota and other places where precautionary data or information was put out in English, but not in Spanish. And then we saw these explosion in cases amongst monolingual Spanish speaking communities. So that's certainly something that we are seeing in the data, at least nationally as well. Thank you for the question.
Janine, if you unmute yourself, you can ask.
Yes, thank you. And thank you for your talk. My question is, with regard to distrust, have you started to look at the care that patients are getting in relative to the race, and whether the patients are getting the same amount of care depending on their race?
We haven't looked at that. We were more interested in looking at data that's available at the county level, and you really don't have that type of information down to the county level. What I can say though is that we do have data on equity and systems that have more equity. So for instance, for HIV, we have the Ryan White program where there's more equity that's given in terms of care by race and ethnicity. And what you see is very few disparities in terms of viral suppression by race or ethnicity in the Ryan White program. We're seeing actually the same thing with the VA. The VA, does a very good job of viral suppression by race and ethnicity because there is more equity within the VA system in provision of healthcare. There's actually a paper as well that is hopefully coming out fairly soon of the VA, where they looked at several thousand VA veterans, and they found greater rates of COVID-19 among Blacks and Latino veterans. But when they looked at mortality, there was no difference by race. And the takeaway for me there is because there's greater equity in terms of the provision of care in the VA system, that they're able to really address these disparities that unfortunately we're seeing in the rest of the US because there's less equity in terms of healthcare.
Right. I think my fear is that as the cases increase and the ventilators become less available, that these communities are going to suffer. That's what I'm thinking.
Oh, I agree with you completely there. That we're already hearing that there are some calculations and algorithms that people have in terms of which patients to save and which patients not to save. That's based upon age. That's based upon a lot of other issues that could have implications for people of color, and so that could be an issue as we move forward.